Next, let's take a look at transition of care models for the interprofessional care of older adults. So these are models of care for older adults that are moving from the inpatient setting back to the ambulatory care setting. And there's quite a few of these. There's the TCM model, transitional care model, that is designed to improve discharge and transition of care from acute hospital stays by ensuring follow-up care, providing early discharge planning with the interprofessional team, and providing follow-up at home for 2 months after discharge, comprehensive assessments of person-centered goals and the person's needs and their home safety. And of course, operating in an interprofessional team, including the team leader being a trained transitional care nurse who coordinates care across the interprofessional team. And outcomes, again, are better. Reduced 30 and 90-day readmissions, reduced cost of care at 90 days, and improved cost effectiveness. There's the CTP model, Care Transitions Program. So in this model, which is again designed to reduce readmissions, there's 4 main components that I'll talk about on the next slide. The team meets at discharge and educates the patient on these main topics. And then they provide 2 or more home visits within 30 days of discharge. The interprofessional team is made up of a care transitions coach, usually a nurse practitioner, who coordinates with the interprofessional treatment team at large. And again, outcomes are improved, reduced readmissions, reduced cost of care. And this is what that what that model looks like. They provide education on medication self-management, improving the patient's self-efficacy for taking their own medications, understanding what potential side effects are, and how they might impact their lives, and what to look for when things aren't going right. Providing patient-centered record keeping, connecting the person to their own medical records so that they have some ownership of what's happening in their care. Again, providing follow-up, and of course, warning and educating the patient about what the red flags are so that they understand what to look for when things are going wrong in their care and when to escalate to their providers to get more help. There are other care transition models as well, like Project Red and Boost, that I'm not going to talk about today. Now I'm going to take a few minutes and turn to outpatient models of interprofessional care, starting with the Geriatric Evaluation and Management Model, or GEM. And so this takes some common knowledge in geriatric circles, which is that comprehensive geriatric assessments, which are the gold standard of geriatric evaluations for new patients, are more beneficial to the patient period, and they are again more beneficial when performed by an interprofessional team that is equipped to handle the complexity of that patient. So the GEM team co-manages patients with a primary care doc, either for tune-ups or for long-term care. So it's not that the GEM team is fully owning the patient, they're working with primary care in tandem to give tune-ups as needed. And sometimes when needed, they do take over, but for the most part, it's about co-managing and giving quality tune-ups here and there as appropriate. And so again, composed of an interprofessional team, usually geriatricians, social workers, and clinical nurse specialists, ideally an geriatric NP. And here again, outcomes are improved. Patients less likely to have functional decline or limitations, less depression, less home care services. And primary care, of course, has high satisfaction with this model because they're having some high-quality consultation and their patient outcomes are better. Unfortunately, it is cost neutral, but that's, I suppose, better than cost negative. And then there's the PACE model, the Program for All-Inclusive Care for the Elderly. This is a great program that's designed to provide comprehensive primary care for people 55 and older who would otherwise be candidates for nursing home placement, very complex patients. So PACE programs receive a capitated payment from Medicare and Medicaid. What that means is they receive a payment per head to provide comprehensive care per patient in their PACE program. And so they can do whatever they need to do with those funds to provide comprehensive, high-quality care and avoid nursing home placement. They have complete discretion over their care within the rubric of the PACE program. So they're incentivized to provide high-quality care that limits unnecessary treatment and hospitalizations. And if they do that in a high-quality way, which they often do, they have extra money to fund other programming that meets the needs of their patient population. Does their patient population live in a food desert? If they've managed to provide high-quality care that limited unnecessary hospital stays, then that PACE program would be able to perhaps provide a nutrition program for those patients, etc. And so this flexible structure, which exists outside of the standard structure of Medicare and Medicaid reimbursement, is really ideal for this complex patient group. And of course, it's a one-stop shop. It's occurring at a day health center with everything in that location. And so the whole interprofessional team is there and they coordinate together, and outcomes are great. Enrollees stay in the community longer. They age in place, which is my goal for every patient in our clinic. And they have improved rates of hospitalization, readmission, cost of care, and survival. Then there's the GRACE model, the Geriatric Resources for Assessment and Care of Elders. And so this is another interprofessional team care model that targets low-income elders across 12 domains of care, with the overall goal of optimizing the health and functional status of older adults, decreasing excess healthcare use, and preventing long-term nursing home placement. The interprofessional team is, again, this broad interprofessional team which older adults need, and the outcomes are great. And this is what that model looks like. The team is divided into a support team, which is a nurse practitioner and social worker, and a main team. The support team is responsible for going out to the patient or evaluating the patient in clinic, conducting the comprehensive geriatric assessment, and then bringing that information back to the interprofessional team, who develops a care plan utilizing overall GRACE protocols for each of the 12 domains of care. And the support team then coordinates that care with the primary care doc and implements the plan and tracks outcomes using software and electronic health records. Thinking about these models, right? What are the key ingredients of these models that make them effective in improving patient outcomes? And who's driving the bus in these models? What are the team roles? And how does having a leader and a specific team roles impact care? Pause the video for a couple minutes and think about that and write down your answers.